Thank you, Dr. Purvasa and Dr. Jaya, for inviting me to this. I think most of the discussion have already been done by Dr. Prafulla and Somshila ma'am. So I'll just skip to the case that I'm going to present. So this was the case. It was a case of 14-year female patient with IFC with Hydrops. And you can see the fundus picture. Of course, this was after the Hydrops healed. And this was the other eye. So we went out with this technique. This is Dr. Basway's technique. Initially, we used to do pre-op AIOCT based. Now, since we have microscope integrated OCT, we use this. So here, as you can see, it was a case of yeah. As you can see, the DM was not detached here. What we could see, only the problem was fluid-filled pockets, and the patient was non-resolving even one attempt of C3F8, because C3F8 probably wouldn't have helped in this patient because DM is already attached here. So what we did, we went out with MBR knife and made some venting incision, draining from the fluid pockets. The MIOCT helps you to directly monitor where you are going into, whether you are into the cavity or going somewhere else, and massage with and filling the entire interchamber with air. That helps you to resolve the cases. So this is a brief video of that, and this was the patient. As you can see, it resolved within 1 week, and this is the extended version of the division. Just I would like to continue a few things. Yes, so at times it's not that easy. As you can see, a lot of bleeding happened in this patient because there was a limbal vascularization was there. However, in the end, after repeated massage, we could take out fluid from all the cavities. So the techniques works by Dr. Rajesh said. It's not the basically this compression suture or draining by MBR knife. It's all works by taking out the fluid from the fluid pockets, which might have taken almost 2-3 months to resolve. So this we published. So recalcitrant hydrops, yes, I missed that slide. Recalcitrant hydrops, as sir was saying, we don't do these techniques directly for every patient. We give one attempt of C3F8. If that doesn't work, then we go for this. However, when a patient present, like this was the case of 6 patients we published. Of course, it's a letter to editor because the editor was waiting for Sibelman to publish one case. Then only they let us publish our 6 cases. So the thickness was more than 1600 in all these cases, and this technique worked well. All of them resolved in 4 to 6 weeks, except one patient where the symptom increased at 6 weeks. But however, that also resolved with medical management only. So these are the few cases that in which we did this case. And compression suture, DMAG, yeah, these are the techniques that have been described. So each time we discuss about Hydrops, then I go back and re-evaluate my post-op pictures. Then what my observation is that if you see this image here, there is not much fluid pockets here. In these patients, probably simply doing a conservative or C3F8 may work. But this was the patient where I was showing you. As you can see, a lot of fluid pockets were there, but not much DM detachment. Probably in this case, a partial thickness suture or drainage using venting incision would help. This is a case which, one of my case which resolved with this stream technique, but you can see there was a gap. Okay, and that there was a gap between the posterior stroma and the DM2. Probably retrospectively, what I feel in these patients, probably a full thickness suture would have helped in opposing the DM to the posterior stroma. So it has to be a case-based approach. One technique doesn't fit to all spectrum of Hydrops. Conservative measures, yes, you should try if the Hydrops is mild. That was the MIOCT grading which Dr. Jaya was saying, less than 3, 3 to 5, more than 5, less than 3. There is always a road. For recalcitrant Hydrops where one attempt of C3F8 has failed, maybe all these techniques should be done. With this I'll conclude here. Thank you.
Thank you so much.
Okay, these are few cases. Yes. Like there was a discussion, vascularization, melting, fistula, all this can happen if you don't treat these cases in timely manner.
Prafulla, in your case, your OCT did not pick up the breach. If you use a UBM, because even to the date, I see every month one forceps related eye drops in a unit, and I also see a PCG where having an eye drops. So this kind of a cleft is seen when you have a track. UBM actually picks up that communicating track.
We had a publication on UBM too, sir, long time back, but we have realized that ASOCD can also give you those tracks, because we have seen tracks in few patients, and whenever we find such tracks, we avoid this technique because that will create a direct fistula to the external surface. So we avoid those techniques. ASOCT also fair enough to give you, but yes, if edema is too much, it's a hazy cornea, then UBM would be better than ASOCT.
So the compression suture generally resorted to the moderate to severe cases, where this is mechanistically addressed the corneal weakening, because it's unable to contain the biomechanical stress. So we want to obliterate the potential space between the descemet endothelium complex from the stroma. So whereas in an air bubble, I think it doesn't do that thing. It's something like offering a band-aid for a bullet
That
injury.
tamponade for that brief period only, so that it
Other
goes.
potential disadvantage of air for a long time, let's say you use a gas which tend to stay for about 4 weeks, it is potentially toxic to endothelium. So see, one of the reasons we have an extremely good outcome following a keratoplasty is the peripheral endothelial reserve. You end up compromising that endothelium by injecting a gas, so it actually defeats our purpose.
That's what I would say. The gas is endotheliotoxic. That's based on experimental studies only. Clinical studies haven't proven that. So I'm not saying you may be wrong, but for an institute like LVP or RPC, maybe putting compression suture is okay. But for practitioners, it's
you have to
highlighted.
look at the anatomy of it.
Yeah.
What he is mentioning, that if you have a break, you can tamponade it from within by putting a gas bubble. But if you have a cornea that's swollen, unless this break is completely covered, the fluid will continue to leak. So that potential space has to also to be reduced. So that's where the compression
So such
suture,
cases,
it
it's a must.
compresses the corneal stroma. So whenever the fluid leaks out, it basically improves the, they both work synergistically, the gas
Yeah,
or
for
the
such
air
cases,
and the
definitely.
sutures. Yeah.
As I showed in that picture, for such
And
cases, compression
between
suture has to be
OCT and
done.
UBM sometimes can give you a wider range of, where OCT you may lose, because if there is massive edema,
But-
your screen may not capture the entire thing. You may see the top, you may not see the bottom, So, and if there is severe edema of fluid pocket shadowing, so you don't see the posterior imaging very clearly. UBM in those scenarios can give you a much better picture.
Yes, but
Although
sir,
the newer OCTs
uh-huh.
are better, they have
Yeah.
a wider range.
So UBM, as I said, we used to do that regularly in all cases, but the quality of image that used to get is not that good like ASOCT. So at times even it's difficult to identify where exactly the DM is. So that was the issue. That's why we shifted to ASOCT.
Thank you so much for